breast cancer is really heterogeneous. Um, they can be, first you look at the stage of the cancer. Stage means, the size of the tumor, whether there's any apparent lymph node involvement, whether there's obvious metastasis, and then also the tumor pathology, like these include tumor grades and, of course, estrogen receptor, progesterone receptor, and HER2 status. And all these can affect what we do. Additionally, patients' age, comorbidities. Just give you some examples. For example, if I have a patient who's postmenopausal and she had a mammogram kind of screening and identified a 1 centimeter like tumor and biopsy, that's usually the first thing that they would do. They would do an ultrasound guided biopsy most likely, and then showed this is an invasive ductal cancer, which is a very common, most common subtype, and it's regardless of the subtype because it's so small. For example, if it is ER positive and HER2 negative, in this patient, the first thing they do is they go to surgery. They will have the breast cancer removed. They will have axillary lymph node assessment. Usually they do a sentinel lymph node biopsy, and then they will see us again and decide on whether the patient needs chemotherapy, does she need radiation treatment, and based on biomarkers, like they may be offered with hormonal therapy. If it is HER2 positive, they may be offered HER2 target therapy. But then some patients, if they come in with a bigger tumor, like for example 4 or 5 centimeters, and they desire breast conservation, or if they're HER2 positive, triple negative, we tend to give neoadjuvant treatment because we have actually additional adjuvant therapy available now for triple negative cancer or HER2 positive cancer patients if they had residual disease from the neoadjuvant treatments, like the Kadcyla for HER2 positive breast cancer and the capecitabine for triple negative breast cancer. And so we have a lot of options